Welcome to the Illinois Primary Healthcare Association's Health Talks podcast. On this podcast, we highlight incredible individuals who advance community healthcare, advocacy, and public health while striving to improve patient care. Welcome, everyone, again to IPHCA's Health Talks podcast. We're really excited that you are back with us today. I'm really excited for our next guest. We are here with Dr. Alexis Braverman. Dr. Braverman is a board-certified OBGYN at UI Health. She completed her medical school at Sidney Kimmel Medical College of Thomas Jefferson University in Philadelphia. And that's where she first became passionate about providing full-service care for pregnant patients with OUD, or Opioid Use Disorder. She completed her residency training at the University of Illinois at Chicago and continues her work there today as an attending. Dr. Braverman is with us to educate colleagues in all fields about OUD and pregnancy and hopes to improve the systemic stigma and bias that patients routinely experience. Dr. Braverman, thank you so much for being here with us today.
Thank you so much for having me. I'm so excited to be here.
Yeah, I'm so excited to talk to you about this. I know you have a very busy schedule, so we appreciate the time that you're making. Let's get into it. So as I'm reading your bio, it says that you first became interested in working with pregnant patients with OUD in medical school.
Yeah, that's true. I actually did a psychiatry rotation when I was in medical school at a outpatient methadone clinic that in particular served patients with opioid use disorder who were pregnant or had children under the age of 2. I spent about a month there and had been to do some rotations at other methadone clinics and just saw how different this experience was. So the patients would come there, they had childcare, it was bright and lit, and they did groups. And then the part that I didn't realize at the time was so special was that there was a direct relationship between the Thomas Jefferson University Hospital and this clinic, where when a patient would be admitted for stabilization, at that time it was really only methadone, to the hospital, and everybody who was in Philadelphia would come and get stabilized at Jefferson. There was a direct relationship with this clinic. So somebody would come from the clinic, speak to the patient while they were inpatient, get them set up as outpatient care at the methadone clinic, and then on whatever basis they needed based on their other medical or surgical complications in the pregnancy, the team from the clinic would accompany the patients to their OB appointments. And so there was a real integration, and it was a really well-oiled machine, and it really was such a nice experience, I think, for the patients to have that integrated care when they were already dealing with so much in terms of their recovery, their stabilization, multiple psychosocial things that are going on in that situation. And then to not have to worry about that administrative piece, about getting the care in a place that was really comfortable providing their prenatal care, I think was really helpful. And when I came here to residency, I saw that that was actually a really unique scenario. And that was one of the things that seeing patients being cared for in that manner was one of the biggest pieces that got me interested in the work.
Yeah. I'm super interested in that. What do you think it was about seeing that for you that made you interested in it?
I think that being able to spend time in a clinic where everybody was really working towards the same goal at helping patients achieve recovery, and in addition to meeting their life goals, which for many of these patients was parenting, really, really emphasized how important this work is and how impactful it can be in the patient's lives. And of course, it's not just the medication. There's all the other pieces that are important to supporting patients, the group therapy. Usually there's often going to be some psychiatric or trauma-related diagnoses as well. And all of that was getting done in the same place by the same people. I feel like the patients were getting better faster.
Ooh, yes, because of the integrated care, because you were addressing all these other things in addition to drug use.
Yes, and they were also presenting for their prenatal visits, because probably a little bit because they had to, right? They were physically brought there by the staff. But that also helped decrease the stigma, I think, for those patients, because it was a supportive environment. It was an environment that was comfortable providing prenatal care for patients who were using methadone for opioid use disorder. It helped the patients have a more successful pregnancy and do the things that allowed the pregnancy to be healthier.
Yeah, like this is just part of our routine care. We're not splitting
Exactly.
these things off. That's very cool. So, can you talk a little bit about in your work now? Because I would imagine maybe it's integrated, but maybe not as much.
Yeah, I think
Yeah.
that there's been a big transition. So when I started as an attending at UIC back in 2018, there were a few family medicine physicians at UIC that were particularly interested in this work. I was the only person in my department who was really interested in this work. And so I had the opportunity to be mentored by some fantastic family medicine physicians who are still at the institution, and that group has grown. And so at the time, my dream was to have an integrated clinic
Hmm.
at Mouse Square, which is our FQHC that's associated with UIC. The problem that I ran into, that I think is one that maybe a lot of people that are interested in doing this work run into, is that you can't do it alone. And it does require supportive colleagues, and not that I don't have supportive colleagues, but other people that want to do the work with you, because you
Yes.
can't work 24 hours a day. And some of this work does require access. And so I tried to do that. Some of the other logistic issues that we ran into were that I was there on Wednesday mornings, and patients don't always need OUD care on Wednesday mornings.
Hmm.
And so
Right.
that's another thing to say, that having a bunch of people that are interested in the work is helpful.
Yes.
So the way that we do it at UIC now, which has, developed over the last 8 to 10 years, is that the family medicine department really does do the bulk of the work for OUD care and pregnancy. And that's really nice, because they are comfortable with prenatal care, they're comfortable with the OUD care. And then when there's a patient who is more obstetrically complex, either because of their surgical history or their obstetric complexity, then they reach out to me and I will care for the patient or
Okay.
collaborate with them. And so that really works nicely for us. Also, the benefit of having primary care physicians do it is because then the patient eventually is not pregnant anymore,
Hmm.
and then already has an established relationship with someone who can care for their OUD and care for their any other, medical issues or their primary healthcare needs,
Yeah.
which is really nice. They're able to dispense methadone at
Hmm.
Mouse Square, which is new. They have the capability to provide that full scope care. So it's gotten much better. It's not through our high risk OB team, which is what it was like at Jefferson, but it's a different model that I think works really nicely and does allow the patient to have as full scope kind of prenatal and OUD care as possible.
Yeah, that's great. So you have a partially integrated system in a new place at UIC.
Exactly.
And you're mainly working with patients probably that already are aware of and able to talk about drug and alcohol use. But I'm wondering about what your philosophy is around maybe if you did a screening and you see something that's on there, maybe a first conversation with somebody who's pregnant around drug and alcohol use. How do you think about having those conversations?
Yeah, it's a really good question. And I think the state has done their best at providing resources. The ILPQC, their Illinois Perinatal Quality Collaborative, has done a really good job at making this a priority with the Mothers and Newborns Affected by Opioids initiative. And part of that initiative, which we integrated into our work back in 2018 at UIH, is to screen, right? and
Hmm.
and there is a lot of data about screening, and one of the real hallmarks of it that we have taken is that to screen everybody at every physical space that they interact with the medical system. So we do it as an outpatient for new OB visits, but a lot of times patients with opioid use disorder, where they're not ready to come to care yet, they're not going for a new OB visit right until very late, but they might come for nausea, vomiting, and pregnancy to the OB emergency room, or
Yeah.
they might come for abdominal pain or bleeding. And
Hmm.
so that's been a real opportunity for us to screen people, and we have gotten that into our nursing workflow. We screen with the 5 Ps, which is not perfect, but it is an opportunity to open the door for conversations. And so that, I think, is the philosophy, is just kind of starting to ask the question and make sure that you screen every patient, regardless of whether you think that they might or might not have opioid use disorder, and for any concern, right? That you're not just talking to people that are coming in withdrawal or with concern for overdose, but that we're catching people well before that, who are there for non-related concerns. The earlier you establish care for OUD in pregnancy, the better the neonatal and maternal outcomes. And so finding opportunities to achieve that screening and those conversations early are the best.
Yeah, like we're not restricting screening to certain types of people or certain types of
Exactly.
appointments. We are screening whenever the patient walks in the door, essentially. That's the ideal.
Exactly. And not everybody is ready or willing to talk about it or
Yeah.
come to care. And that's okay. It at least provides us an opportunity to start that conversation, provide resources, provide phone numbers,
Hmm.
talk about what care would look like if and when a patient does want to come to care. But it's a touch point.
Yes, absolutely. So you mentioned the 5 Ps, and for people that don't know, do you mind just briefly walking us through that?
So the 5 Ps is a short screener. It's a validated screener for substance use in pregnancy. It actually is not specific to opioid use disorder.
Hmm.
The Ps are parents, peers, partner, and past and present. So the idea is that people are at risk for substance use, even if they don't use substances themselves, and that might be an opportunity for intervention with providing resources or support, even if they are just at risk. So if their parents have had issues, if they have peers that are using drugs and alcohol, if their partner has substance use disorder, those are things that all put them at risk, even if they themselves are not using
Yes.
any substances. And then I think a good question that I've developed from interacting with this screener, I've used this in my kind of normal H&P that I do with patients, is I always ask, do you currently use any tobacco, alcohol, or drugs? And then have
Hmm.
you ever had any issues in the past with drugs and alcohol? So I find that a lot of times patients are, maybe they have a history of substance use disorder. It's no longer an active issue for them, and they're not eager to chat about it. And
Yeah.
that's understandable based on the stigma that is well documented that patients have regarding issues with drugs and alcohol, in particular in pregnancy. But asking about that is really important because maybe they don't have an issue now, but then the pregnancy provides extra stress, and certainly relapse is always an issue. So if you don't ask about it, then it's easy for it not to come up. And then
Yes.
if somebody says yes to any of those, then that requires further assessment for any active and problematic substance use, which then can be dealt with.
So I just want to highlight something you said, which is the screening tool, which one option for people is the 5 Ps, which would ask about typically present drug and alcohol use issues. But you're saying it's also important to ask about history of drug and alcohol use and have you ever had an issue?
Yeah.
Because pregnancy is going to increase stress. And as we know, that could put somebody at risk. When they're stressed, they may go back to things that have helped them in the past.
Yeah, absolutely. And I think it even helps with something as, now this is not a simple drug, but tobacco, right?
Hmm.
Somebody might say, I don't use tobacco, but then you ask them, have you ever had issues in the past with tobacco? And they say, yes. And you say,
Yep.
how long ago? And they're like, last week,
Yeah.
right? Like I quit last week. And so,
Yeah.
but they're not using now, which they're proud of, which is incredible. But they're
Yes.
certainly at risk for going back to tobacco use in the pregnancy. And also, depending on how far along they are, potentially some of those risks impact the pregnancy, even though they're not currently using. So that's
Yeah.
why I think another kind of plug for asking about someone's past.
Right, absolutely. I want to talk about something that is always seems to come up when we're talking about patients in OBGYN, people that are pregnant, is the question of DCFS or Child Protective Services involvement. And not that we always have to go there and bring it there, but I do feel like when this comes up in integrated care and primary care, that's like the medical team's primary area of confusion or fear, and of course with patients as well. I know it's a big area and a big topic, but I would assume you have some ways of thinking about that.
Yeah, absolutely. It's a great question. And this is actually something that I find that patients are really nervous to bring up.
Yeah.
Every patient is obviously concerned about it. And this is a huge reason why people don't come to care, in addition to the stigma, is just
Yep.
concerns about involvement with DCFS. So it's something that I'm really aggressive about talking about as early as possible when
Mm.
patients come to care, because it's like the elephant in the room.
Yes.
And I find that talking about it openly, and of course I have no bearing in that moment on what a decision will be made by DCFS, but saying, I know you're thinking about this. I'm thinking about this too. Let's talk about the ways in which I've seen this play out. Let's talk about the kind of standard practices that the hospital has with regards to DCFS in patients that have had similar scenarios to you. And then what are the things that I've seen are the most supportive of a positive result from a DCFS inquiry in the event that the patient is desiring parenting. And of course, unfortunately, I think we've all seen scenarios where we're like shocked about the decision, but things like coming to care regularly, having negative urine drug screens, or, urine drug screens that are only positive for the prescribed medications.
Yes.
Participating in care, is the biggest one, right? And so a lot of patients, their impulse is to stay away from care, right? Because the care is how the phone calls get made.
Yeah.
That way you are on the same side as the patient. And I don't mean to say that it's sides, because that's not, but that is how it feels a lot for patients. And so, what can we do together to develop a portfolio for you that is going to be as advantageous as possible when DCFS gets involved? Because typically they often are involved, even when maybe sometimes the law regarding mandated reporting does not require them to be involved. Anybody can make a call who's a mandated reporter, and they don't always do it based on what the mandated reporting laws are. So typically, unless their patient has another child, you can't make a call prior to delivery. There's no child at risk.
Yes.
And also, if a patient does not have active and problematic substance use, there's no reason why you have to make a call. That does not mandate a call. So that means that someone who's stable on buprenorphine or methadone, they're taking prescribed medication, they're doing well. There's actually no reason why someone has to call. But I do share with patients that you should be prepared for a call. Often there's somebody who makes a call. And so because of that, what can we do to make a plan and really develop this portfolio that looks good, that demonstrates all of the work that the patient is doing to get their life together in order to position themselves as a safe parent.
Oh, and I love the way that you're talking about this, just so straightforward, because I feel like how we normally talk about it is fear-based, or people just don't know on the healthcare team, and then they're afraid to bring it up. And this is just such a better strategy, just to address it up front.
Yeah, I think that it is too. I mean, there's a lot of question marks, and I just think that's okay to share that with patients. I don't know if someone's going to call. I don't know what's going to happen if they do.
Right.
But these are the things that I've seen work in the past. And that was something that one of my mentors shared with me, that's her strategy. And that way it's I can't promise you anything. This is a system that I'm not involved with, that is confusing to me and a lot of people, but it is a system that we live with, and unfortunately a system that you have a higher likelihood of interacting with. So let's talk about how to position yourself as positively as possible.
Yeah, right. That makes complete sense. It's so in service of the patient and the family and the parent.
I feel very comfortable with these issues, right? So if I don't talk about it in the prenatal period, then now the patient is exposed to a whole new team, a new pediatric team, a new obstetric team. I just feel like it's my duty to discuss it with the patient, because hopefully we have a little bit of rapport. And even to involve social work beforehand can also be really helpful, in particular if you have with a warm handoff, a social worker that has some experience with this. Sometimes I've seen social workers even call DCFS with the patient there to be like, hey, this is the situation. And, of course they're going to say, we can't do anything about it. But at least it's it's an opportunity to engage with a system that is less threatening.
Yes, let's accept that this is a part of what could happen, and address it sort of head on, and demonstrate all the ways that the person's staying in care and doing what they need to do to have a successful outcome.
Absolutely.
So let me just ask, I'm curious, because you had said earlier that in certain situations, maybe by the rule book, there's no reason to make a call from what you said previously, but probably many times a call will be made. Do you think that's because people on the healthcare team are doing it just out of not knowing, or maybe just out of precaution? Why do you think that's happening?
I think maybe it's a little bit of both. I think also sometimes, right, if I've had a relationship with the patient for 6 months, I feel really comfortable that they have a good plan and that they're stable. But then you have a new pediatric team who doesn't know the patient, right? And their responsibility is to the baby, which is appropriate. And so they want to make sure that that baby is taken care of and that they're doing everything that they can to support the health and welfare of that child. And so, that this is another plug for family medicine physicians, right? That if you're doing the prenatal care for the mom and have a relationship with the mom, then you have much more insight as well as many more touch points regarding, touch points with that family, right? Because now you're going to be doing the postpartum care. You're going to know how well that mom is doing postpartum, and you're going to be taking care of the baby, every week, every 2 weeks, whatever it is at the beginning. So it's really hard. Like I don't mean to say that people that are pediatricians that make calls are out, they're doing what they believe is best for the baby. Yes. And this is, for a mom that they don't know.
Right. But again, I love the way you're talking about this, and these are the systems in place, and they're all kind of advocating in different ways, and how do we work together as best we can?
I think one of the things about this care is that once you start doing it, you notice how the medicine part is easy.
Yes.
And I think that that's the part that sometimes scares people because of, and for any of us, even if it's something silly like omeprazole, if you don't prescribe it, then you're not comfortable prescribing it.
Yeah.
But the medicine is actually quite simple, and it's of course the rest of it that is more challenging,
right?
As well as the logistics of the care. Even just do it once, and you can see in front of you how much improvement the patient has. It really can be so supportive of doing more of that care.
Yeah, no, that's awesome. And this has been such an interesting conversation and really enlightening. I could tell just how passionate you are about the work. And we're lucky to have you on the podcast, of course, but also just in our state and city caring for patients. So thank you for that.
That's so kind. I'm happy to be here. And I love it. This has been some of the most rewarding work of my career. So
yeah. And so on that note, as we sort of wrap up, tell me if you can think of just what about it has been rewarding, or is there a patient story or anything that you can share that makes you energized by the work?
Yeah, absolutely. I think that I have two patients that always come to mind. One is someone that I've been taking care of for years. And she was told when she got pregnant by her, I guess it was her psychiatrist, I don't remember who was providing her buprenorphine at the time, that she needed to stop it. And she obviously went into extreme withdrawal. We got her stabilized at UIC, and she had an uncomplicated pregnancy. And she's been my patient every month for the last 7 years. And the other patient is actually one that I never met in person. She came into care with me during COVID when that was possible. And I never met her. And I prescribed her buprenorphine over the phone, in a telehealth fashion.
Yes.
And she went from using heroin consistently and fentanyl to not using it all and having a healthy term delivery. She did so well. Yes. And this was without even meeting the patient in person.
Yeah.
And that just goes to show how simple some of these interventions can be from the prescriber perspective. That can make such a huge difference in the maternal neonatal unit. And so those are the two patients that always come to mind when I think about how impactful this work can be. Certainly it's not always like that. It's challenging to have continuity. It's, but they stick with me as, real reasons why I do this work.
Yeah. Absolutely. Well, this has been wonderful. Thank you again so much. And for listeners, Dr. Braverman is providing another deep dive educational webinar session on this topic and caring for pregnant patients with OUD and other substance use disorders pretty soon for us at IPHCA. So tune into that if you're able to catch it live, or you can find it on demand on our website. Thank you again, everybody, for listening. And tune in to future Health Talks podcasts. Dr. Braverman, thank you so much. Have a good rest of your day.
Thank you so much for having me. This was wonderful.
If you enjoyed today's episode, don't forget to like and subscribe on your preferred platform. It helps us reach more listeners and create more content like this.